Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks. This week, we talked to Dr. Brad Pasternak. Dr. Pasternak is the director of the Inflammatory Bowel Disease Program at Phoenix Children's Hospital. We talked to him about why he chose to go into gastroenterology and how his ulcerative colitis shaped his decision to go into this field. We talked to him about training in Israel and what the differences are between the different healthcare systems. We talked to him about some of the research that he's done, and we talked to him about the very cool volunteer program that he has going on. Cheers.
Hi, everybody. This is Robin. Welcome to Bowel Moments.
Hi, guys. This is Alicia, and we are so excited to be joined by Dr. Brad Pasternak. Dr. Pasternak, welcome so much to the show. We are very, very excited to hear your story. However, we start with a very unprofessional question of what are you drinking?
I am drinking Kate Farms right now. Actually, no, I'm not. I'm kidding. But I wanted to make it.
That didn't look like it.
No, I wanted to make it IBD focused. I'm just drinking a coffee. There's a lot of exciting things going on in Phoenix right now, and we are going to go out tonight. So I need energy.
Oh, how fun. Well, I wish to know more, but we'll hold that thought. Robin, what about you?
I am drinking something that I've never had before. I'm drinking a little hot toddy.
What's in a hot? It's whiskey?
Whiskey, got a little lemon, little honey, little hot water served hot.
Nice.
It's very good. What about you, Alicia?
I got adventurous today and I am drinking it's called a JB Sunset. So it's Jim Beam and cranberry, ginger ale, some lemon. It's okay. I realize that maybe I'm not a Jim Beam kind of person. So maybe this won't happen again, but it's always good to experiment. Dr. Pasternak, again, we are very excited to hear your story. So next question for you is, what brought you into our IBD community? Why did you become a pediatric gastroenterologist specializing in inflammatory bowel disease?
My story it's pretty obvious why I went into pediatric GI after you hear my story. And actually, my daughter just saw Dr. Patel in our group, and we'll get into that. But it was the first time I had to give a family history in a while. And wow, it made me realize either I'm old or I just have too many problems. So I was always interested in pediatrics. It was just growing up. I love science. I love math, and going through just early education, I was going to be a doctor. And that was I never thought about anything else. There was a brief moment where I wanted to be a pilot, and that was short-lived. But yeah, I was headed in that direction just from grade school, high school, and on, and always knew I wanted to do pediatrics. I love kids. I connect with kids. I was a camp counselor, lifeguard. Like my childhood, all my jobs were related to children. So that was an obvious next step. And then in college, in my junior year of college, I actually started having symptoms of IBD. I ignored them for 2 to 3 months because I just thought it was all the fun I was having in college and maybe things would go away, but they persisted. And as many of the listeners or patients with IBD know, it just becomes really unmanageable when you're using the restroom 25 times and at night, and you're in college and trying to go to class and sitting at the back row in the back seat so that you can run to the restroom. So I finally told my parents and got evaluated and got diagnosed with ulcerative colitis back when I was a junior in college. And with my interest in science and medicine, I did research and would read up on it and got really interested in immunology and just the fact that there's no cure. And, at the time, there were no biologics around, and I was treated with lots of steroids. Anyway, I got diagnosed with UC, my interest in science. And so ultimately, that's where I found my passion was in inflammatory bowel disease, more as a patient with curiosity. But fast forward a little bit, and so I'm in med school now, and I ended up going to Israel for my medical school training. So I trained at Tel Aviv University. I trained there, and the training was phenomenal. Smaller class, taught by the professors, very different than training here, where when you're a medical student doing your rotations, you're reporting to an intern and sort of the person with the least experience, as opposed to over there where you're reporting to the professor, a little bit different, but got amazing training. And I remember we had a cell physiology exam, and we were in the library, and I had pretty bad abdominal pain, but I ignored it. And I was flaring at the time. I was on prednisone at the time. The pain got unbearable. And my colleague looked at me, or my classmate looked at me, and I looked pale. I just didn't look well. So he took me into the dean's office, who was a professor who was in the middle of a board meeting. And he saw me, took me to the lounge, examined me, sent me to the hospital. It was okay for a little bit. And then they gave me dinner. I'm not sure why. But right after that, I had just the worst pain of my life. And they took me down. I got an x-ray, came back, and there was a team of 4 to 5 doctors that were standing there. And they told me that I've got free air in my abdomen, which is a sign of a perforation. They thought I had a toxic megacolon because of I was flaring with my IBD. And so they prepped me for emergency surgery. I'm in another country. I have no family there. I asked if I could call my family, and they basically said the OR was ready. I had no time, and my white count was 31, and I was hypertensive. And so they took me to the OR, and lo and behold, I actually had an ulcer in my duodenum that had perforated, and my IBD actually was under control. Later found out that I actually had H. pylori, which is an infection that can cause ulcers, and I was on the prednisone, which kind of affects your ability to produce mucus and protection for the stomach. And I think that combination just led to the perforation. Back in that time, they didn't have IV PPIs. So I ended up having surgery. They did something called a vagotomy, which is cutting the vagus nerve, which stimulates acid production. And they sewed over the hole, and it was an open procedure. I've got a nice scar, a nice battle wound, and everything went well from that standpoint. But since then, I've had some dysmotility issues because of that. And so, that was my second experience with GI issues unrelated to IBD, was H. pylori with a perforated ulcer. Fast forward again to my fellowship. So I did my fellowship training in Cincinnati, which at the time was the mecca for eosinophilic disease. And people would come from all over the world for the eosinophilic disorder program. And I had this history. I've got asthma. I've got a milk allergy myself. And I choked. I've had a history of choking 3 times in my life, requiring the Heimlich. And Dr. Putnam, who was one of my mentors and a big eosinophil guru out in Cincinnati, said, "You've got asthma, you've choked 3 times in your life. I don't even need to scope you. I'm sure you've got EOE." And lo and behold, I've also got EOE. So dysmotility, EOE, inflammatory bowel disease, asthma. I mean, my list. When I was listing it for Dr. Patel, I was surprised he didn't just give me medical leave for a month just to recover from telling my history. But in all honesty, I think it's really made me a better doctor because I share this. It's funny. I tell my patients, like, gosh, I can relate. I seriously have gone through it all. If they've got a diagnosis of EOE, I can go through it. If it's H. pylori, I can talk about it. But more importantly, I think IBD has become my true passion. And that's really where I focus my career on at this point. And I tell every patient that I have it. I think it's actually, I can see the relief on their face when they recognize, like, oh, like, he's got it. He's treating me, so he must know something about it. And he became a doctor, so I'm not going to, pass away tomorrow. So, it gives them a little bit of perspective. I could go even a little further, like even in Cincinnati, when I got diagnosed, it was GI. And then I ended up going to Cincinnati for fellowship. And it was interesting. I focused on basic science. I got a grant called the Pediatric Scientist Development Grant through the NIH, where I did 1 year of clinical and then 2 year in the lab. And the lab I worked in was a molecular immunology lab, really a high power lab. There were, I think, 11 or 12 postdocs, not many MDs. There was one other MD, and I came in without really any basic science experience. So it was a little overwhelming. And I started working on a mouse model of colitis and looking at the effect of microbial products and growth and how various products were increased in patients with inflammatory bowel disease. And we saw affected growth and also a little bit on sex differences between males and females. And it was interesting, but I really, really missed patients. And honestly, waking up at 6 a.m. to give a mouse an enema, I looked at myself one day and said, this is not where I saw my career going. It was very difficult to break it to my mentors, but I had amazing people guide me. They actually steered me towards Phoenix. I never thought I would end up in Phoenix. It was never on my list. I'm from the East Coast, and they said, "Oh, Phoenix is it's a rapidly growing community. They're building a brand new hospital. The people in the group are great mentors for junior faculty, and I just think you get along." And it was February. It was freezing in Cincinnati. I flew out to Phoenix, and I just said, "I'm done. I'm sold." And I've been here. I've been in Phoenix for 16 years now.
And you haven't melted yet.
No, in fact, it's in Phoenix. In New York and in Cincinnati, everyone goes away in the winter, escapes the freeze. In Phoenix, we leave in the summer, and it's just the opposite. And even in the summers here at night, everyone's got misters, everyone's got pools. It's very, very livable.
This is not IBD related question, but you said that they surgically altered or cut your vagus nerve?
Yeah, so they did something called a vagotomy.
Don't you need that?
So there's branches of it, and they do something called a selective vagotomy. So they don't cut the entire nerve, but they cut a portion of it that leads to the increase. They don't do this anymore. This is not a procedure that's done, because if a patient comes in with significant abdominal pain and you scope and see it doesn't get to the point of typically a perforation usually, and you can do IV high dose PPI. And that'll heal an ulcer. So that's not a typical procedure done these days. Okay. But granted, this is 20 years ago, which is crazy to think about.
Yes. Yeah. Oh, I understand this very well, because there's plenty of times where I'm like, just the other day. And I was like, no, that was 20 years ago, Alicia.
Right. Yeah.
It's sick and it's wrong and I hate it. Okay. This is not about aging. I'm very curious. You're the first person we've talked to that did their training in Israel. And I know that Israel does, they have totally different things they can do research on. I know a lot of, for instance, the research on marijuana and marijuana use comes out of Israel because they actually fund it, unlike us. Can you talk a little bit more about the healthcare system there?
Oh, yeah.
A little bit more about what that was like, and kind of what's the juxtaposition and now trying to work here?
Yeah, absolutely. So, medicine in Israel is definitely not third world. It's extremely advanced. Like you said, there's a lot of research. The capsule, for instance, was developed in Israel. And from an IBD standpoint, we know that Ashkenazi Jews are a high prevalence population, and there's a lot of inflammatory bowel disease in Israel, and great doctors. Dan Turner's in Israel, and I had some amazing mentors there. So the Israeli program is very different. And the way their program is set up is they go from high school to basically a combined college medical school, 7-year combined program. And then they do 1 year of stage, which is their internship per se, and then training from there. They also have to join the Army at 18. So there's a little bit of a hiatus when they go to the Army. But from a training perspective, like I said, the professors were phenomenal. And when we went to do our rotations, we were taught by the best. And as far as the system, they have universal healthcare. So very different healthcare system than America. The caveat being, many of the doctors would have little private clinics on the side for more affluent patients that would pay out of pocket for their procedures. And so that's how the physicians, I think, really were able to make ends meet, because in the universal system, I guess things are capped, but they're able to do these private practices, private clinics. And when I came back to the States, again, when I did my residency in Brooklyn, and it was in a Kings County hospital, which is the middle of sort of the really bad area of Brooklyn, and we saw everything. And one thing I always tell medical students and learners is, when you're looking for a program, you want to be at a place where, for residency, you want to go to a resident-run program where you make the decisions. You're the final call. Not necessarily a big place where there's tons of fellows and you're just an intermediary between the patient and the fellow, and you're calling the fellow, and ultimately the fellow is making the call. And then when you switch and you go to fellowship, it's the opposite. You want to go to one of these centers where they have a very autonomous fellowship program. And so Kings County and Brooklyn was amazing for training as well, because we were it. Often we were the only ones around, and I did a ton of procedures and came in. I felt extremely well prepared from an education standpoint, probably more so than a lot of my co-fellows that were trained locally. So
that's very cool. And it's so interesting. And I'm sure it was really interesting to come back with that in different type of institutional knowledge, and perhaps also be able to share some things that really worked well in the other system as well. So that's really cool.
Even culturally, like just being able to live in another country for 3.5 years and assimilate. And when I was there, it was during the Intifada, which was pretty crazy. I mean, there were bombings on a weekly basis. It's obviously my parents and family were concerned, but when you were there, you didn't feel it. And whether the media sensationalized it or made it seem worse than it was, like, I'm not going to say we felt 100% comfortable and safe, but we definitely did. It didn't affect our daily lives. And it was really interesting to go through that process. And we would hear bomb sirens go off and we would have to take shelter sometimes. And I mean, it was kind of crazy.
Did that change the way the hospital was set up? Because I mean, I guess I'm thinking of like someplace like Houston, after they had a really bad flood, they ended up restructuring the hospital because it's messed some stuff up, basically. So I'm curious if you're in some place where there's like bombings, war happening, whether they're like, okay, the operating rooms are not at the top, or like we put them here because you can't stop operating even if there's a bomb. So did it change the way the hospital was structured?
That's a great question. I think that the hospitals were kind of structured, already built for conflict. And the other interesting thing about it is they would treat the Palestinians, like if they got injured, they would send them to Israel to get treatment. So it's just an interesting sort of dynamic.
That really is interesting, huh? That must have been very wild to live through, I'm sure. I'm curious because when I looked you up, so I do try to do a little bit of research on our medical guests, especially if they're researchers like you. You have a lot of research that I found that was related to Crohn's. So I'm curious, so you yourself have ulcerative colitis.
Correct.
And how did you end up looking more at Crohn's disease?
In all honesty, it's different opportunities that presented themselves, and there's probably more research and more data related to Crohn's, I think, overall than ulcerative colitis in general. But it's not because I chose Crohn's over UC. It's just sort of the field in general. And I was part of the NASPGHAN. I still am part of the NASPGHAN IBD committee, and through that I worked with Ed DeZonin, and we put together the guidelines on perianal disease treatment. And then I was asked to give a talk in NASPGHAN about perioperative Crohn's disease. And so we recently published a review paper on just the management of perioperative Crohn's. But no, I mean, I don't discriminate. I have equal interest in both disease states. And, it's interesting. People always ask, like, wow, which one would you rather have? And is one better than the other? And, if you think about complications and risks and long-term stuff and growth, Crohn's is definitely the one I would not want to have. I mean, perianal stuff is terrible. And then they say, oh, well, ulcerative colitis is curable. And that's always kind of none of us like to hear that. It's not curable. It's like you're trading in a Jaguar for a Volvo. It's you're getting you don't have Volvos, right? But that's how it was taught to me. It's not like we were talking about a pouch. It's not like a pouch. You're back to normal. No, absolutely not. Your bowel movements increase. They're looser. You may have nocturnal symptoms. Then there's pouchitis, and ultimately 10 to 15% may end up with Crohn's. And then on top of that, we leave, our surgeons leave some of the rectum. There's a stump there, and that's just as prone to having colitis or cuffitis as it was previously. So it's not a cure by any means. I mean, definitely there's improvement in quality of life, but you're sort of trading in one condition for potentially other issues.
Can we all just agree that rectal cuff is not the best name? Can we come up with something different?
I don't even like, nubbin, I have to talk nubbin? About rectal cuff, and I don't like saying it. What did you say?
Like a rectal nubbin? I don't know.
I don't think I like that either. I don't know what's best.
I don't think there's a mini. Well, it wouldn't even be mini.
It's the most appropriate, Alicia. It really is.
No, but it's just so weird sounding. I guess
rectal belt. No, that's not great either. I don't know. No.
All right. Well, we'll workshop this on another day. What a weird question to ask people too. Which would you rather have? Like, listen.
Well, clearly none, but that's not an answer.
Do I have a choice? For me, can I go back to when I was diagnosed with ulcerative colitis? Can I go back to there? No, it's too late. They changed it to Crohn's. Can't go back.
Oh, so you have Crohn's now?
Yeah.
That's the
She's
most.
one of those 10 to 15%
Yeah,
people.
no.
Yeah.
Those are our most complicated patients. I definitely think that those are the ones that are the most difficult to get under control, most frustrating for sure, because, obviously the disease changes and things don't get better when you think they should. And definitely of all my complicated patients, it's the ones that have Crohn's that we thought was initially UC and have gone through a colectomy and then never improved, that are the most difficult.
How do you work with? I mean, I guess that is my question, because if Crohn's is looking like ulcerative colitis when you're starting to work with patients, how do you try to at least guarantee that you're getting that right?
Well, I would say there's definitely no guarantee.
No.
With the exception of guaranteeing it's Crohn's. If you've got significant granulomas, you've got perianal disease, a fistula, that's Crohn's, that's a guarantee. But in pediatrics, the majority of our patients present with pancolitis, for instance. And pancolitis, it could be Crohn's, it could be UC. You have no idea if it's either one. We typically call it indeterminate. And I tell my patients, at the onset, the treatment is similar. And we use the same drugs. And yes, it's important to know the difference because we want to counsel you on potential complications. And sure, there are some medications that do work better in a 5-ASA. I don't use in Crohn's disease at all, and I use in ulcerative colitis. So it's important for that. And we use all of the tools that we currently have available to really try to differentiate. So, every patient at baseline in our group gets imaging, an MRE or a CTE or a capsule to try to at least look at that small bowel and see if there's any abnormalities. And the serologies, they were something we used, a lot in the past. I think they've grown a little bit out of favor in terms of diagnosing, but they're helpful in prognosticating, where kids with multiple antibodies that are positive, then the likelihood of them going to surgery is higher. But that's something that still we can use, and we get the printout, this is more likely Crohn's. If you've got a patient who's ASCA positive, CBER positive, it's more likely Crohn's. And so we use all these various tools to try to at least give us more of a say. And here's a little plug for intestinal ultrasound, because that's becoming a really, I'd like to say it's a hot topic. And it's a new entity that amazes me that it's new, because ultrasound's been around for ages, but really understanding inflammatory bowel disease in ultrasound is new. They use it a lot more in Europe. Interestingly, in pediatrics, there are not many centers that do it. I can tell you Mount Sinai, Marla Dubinsky, Mike Dollinger. So they've really taken the lead in it. And I know at CHLA, they have a physician that does it. And I venture to say that's it for pediatrics. But they've created a program. And so I actually went to the first course on intestinal ultrasound, which was held in New York. And there's 3 modules, and you've got to go. So you do the course, you learn it, and they have patient volunteers. And then the next step after you do it, we have to get the machine at our center, and we've already asked for it at our center. And then you actually go to a center and spend 4 weeks only doing ultrasound to get credentialed. And the benefit of it is you can come to clinic, and we do it right at bedside. It takes 5 minutes, and you can see inflammation, you can see transmural inflammation. And so it can really help identify a flare rather than going through an MRE. But that's also something that could be used for differentiating Crohn's from UC. But unfortunately, there are the patients that really look like UC, and you go down that path and you're pretty convinced, and they get the colectomy, they get a pouch, and their SED rates never improve, their growth never improves, their fatigue never improves, their anemia never improves, etc. And lo and behold, you rescope, and they've got ileal disease, they've got small bowel disease, and now you tell them that they're not going to need a med because they've had their pouch and they're back on a biologic.
Yeah. I'm glad that you mentioned the ultrasound. I was actually going to ask you that next, and you just rolled right into it. I was going to ask if you'd done the class, started to learn about it, or bringing it to
that's my ask for Phoenix Children's as well, is to approve our ask for the ultrasound machine. It's because it's going to change the way we monitor. Mm-hmm. And on top of that, the patients will see it. You're showing them, you're like, look, and they're going to be more apt to change therapy or do what you think is the right thing because they're seeing the inflammation in real time.
I'm glad you mentioned patients being part of this discussion and part of this treatment decision. One article I found that you had written, you were part of a writing team on, was doing some research about treatment adherence and utilizing text messages to try to keep kids to try to remember to take their medicines. Tell me about your interest in that and tell me about this research. What are some other things that you do with the kids to try to get them perhaps more invested?
Absolutely. Yes, that's a great question. So that was a project that I had done with Dr. Milo when he was in town. He did he initially looked at it in the liver transplant population where compliance is imperative to avoid rejection. And we've got all this technology, like every kid's got a cell phone, right? I mean, we've got all this technology, and why not utilize the technology to improve adherence? And I mean, it was a simple concept and simple project where there was a company that we randomized patients to either get a text message or not get a text message about medication reminders. And if they were randomized to the text message group, they would have to respond. Like once they took their medicine, they would press a button and it would log it. But if they didn't, then the parents would get a message that they didn't take it. And so there was kind of a self-check. And obviously the patients that got the text messages were more adherent and did better than those that didn't. It was one of those pretty obvious, simple studies. And some of these companies, like Humira, for instance, they have their patient advocacy programs and resources. They have a text messaging system. I tell all my patients, sign up for it, because it will remind you to take your medication. So some of these companies actually incorporated it into their patient assistance programs. But I agree. Shared decision-making is key. You need buy-in from the family. And so I always discuss the options. And I tell them, then they say, well, what would you do if it was your kid? And, I'll give them my opinion, but ultimately it's their choice. And it's based on their lifestyle, how busy they are. Would they rather an injection versus an infusion? But sometimes infusions are the better drug. And regardless, it's a discussion with the family of here's the data, here's the benefits, here's the risks, and these are the options. And, let's talk about it. And it's your decision.
Yeah, I think that's so interesting. And it would be fun to try to look at, are there any of these apps that like remind people that have that sort of gamified aspect of things, a way to sort of do some reward? Because people do tend to respond differently to things that are like have that gamified aspect of it.
Sure. And I'm sure they exist. When the second you think of a great idea, you search and it's already there. I actually had this whole idea about the bathroom rating. I was so excited about it. And I said, there should be a Yelp for bathrooms for people with IBD. And lo and behold, like a month later, it's, Find My Bathroom app. I think it's through the Crohn's and Colitis Foundation. And I was like, gosh, you can't even come up with an idea anymore.
They stole it from you, I'm sure. They were listening.
I think so.
I think they should give you credit. Okay, I've got 2 wildcards questions for you, which we may have to go there. You had an article about exposure to lipopolysaccharides.
Yeah.
Can you explain what the heck that is, number one? And then also, how would one be exposed to these?
Okay, yeah. So that actually goes back to the research I was doing in Cincinnati. So lipopolysaccharide, LPS, is basically it's a product of gram-negative bacteria. And so, the hypothesis of what causes inflammatory bowel, there's been a lot of research and things have moved extremely fast because our techniques are much better. But the thought is that there's some genetic mutation, there's a genetic predisposition. And when I was in Cincinnati, the first gene was discovered. It was the NOD2 mutation. Interestingly, NOD2 plays a role in recognizing certain patterns on bacteria. So it's part of the innate immune system. Since then, there's about 200 different genes that have been identified, and the majority of them play a role in the innate immune system or the adaptive immune system and play a role in how our body responds to bacteria. So there's this genetic predisposition. There's something in the environment that, we have yet to discover, but it's definitely going to be a culmination of things, whether it's our Western diet or viruses or medication. I mean, who knows what the ultimate triggers are that leads to our immune response, an abnormal immune response to bacteria. And so, that's the hypothesis. And so LPS is a product that is produced by gram-negative bacteria in the gut. And what we showed that our mouse model as well as patients had increased levels of bacterial products in their bloodstream compared to controls, which is what you'd expect. The other concept or the other part of pathophysiology is this barrier, this protective area, the epithelial barrier it's called, is permeable. So, you could ask any GI doctor about what they think of the term leaky gut, and I'm sure you would see a cringe. But in essence, it's a leaky gut. Things are crossing over because of inflammation. So the bacteria cross over. It's called translocation. They cross over and they get into the bloodstream. And so we were able to measure that. And ultimately what we showed was it played a role in affecting growth in kids with inflammatory bowel disease, with Crohn's disease. And so that was sort of the concept behind that project, which was, again, at the bench, working with mice, and not where my career has led or where it is currently.
But how does one not be exposed to these
Oh,
LPS?
No. So everyone's
You
exposed
can't
to
stop it? Oh, no.
Correct.
Okay.
Correct. No, you can't. Everyone's exposed to bacteria in the gut,
Yeah.
but not everyone has IBD. So
Right.
that's why you need that sort of trifecta. You need to have the
Got
genetic
it.
predisposition, and you need to have that second hit. You need to have that trigger, and in combination, then that gut bacteria that is normal, that our body typically should be able to handle, all of a sudden is not handled. And the immune system sees it as an enemy, sees it as an infection, mounts an immune response.
Okay. Got it. Because I was like, let's just avoid this, but sounds like I can't. So
No, you could just treat the downstream inflammatory response, right? But I know that they're working on things to try to improve the barrier, maybe stop the leakage. But yeah, there's been a ton of products and biologics and small molecules. It's been rampant what's been going on in industry and these new meds coming out, really focusing, everything is trying to focus on different portions of the immune system.
of the ones that are coming out, what is the most unique and has the most promise, do you think? Just personal experience.
Great question. We have a little bit difficulty in pediatrics because the only approved biologics in pediatrics are Remicade and Humira, but yet obviously we need to use the other ones when patients fail. But we don't have as much experience as in the adult space where they could just write for it and get it approved. However, what we're seeing in the adult data, the IL-23 specific inhibitors, so Stelara is an IL-12/23 inhibitor because it works on something that is involved in both pathways. But what we've learned is the IL-12 is probably not very important in this whole inflammatory response. And so focusing directly on IL-23, what we've been able to, or what they've been able to do, is give somewhat higher doses, and it's more specific. And the data is really promising in the Skyrizi, for instance, which you've probably seen a billion commercials on. That medication has a lot of promise. And Marla Davinsky just came to Phoenix Children's and gave grand rounds and kind of met with us. And she has the same enthusiasm around IL-23 specific meds. And then the other one are just all these oral medications that are coming out. You know, we're so used to injections and infusions, and immediately parents freak out because they just think it's, and I always tell them, I said, just because it's given in a needle does not mean it's more powerful. In fact, prednisone is the worst drug you could take. And that's a pill. So I have to calm their nerves about the fact that they're doing an infusion or an injection, but something like the JAK inhibitors. So Rinvoq, the newer one that came out, Xeljanz, these also show a lot of promise in the space and have been very effective, and they're very fast. They work quickly. Within, data shows even within 2 days, there's improvement, but really 2 weeks and you're seeing significant improvement. So those are encouraging.
Yeah, that's really encouraging. I'm sure that patients would be stoked to take something that acts that quickly because, they feel terrible.
Unfortunately, the labels say you have to fail a TNF before you start it. I think that's the hardest part of our job now, is figuring out where in this algorithm do we utilize these drugs, number one. Yeah. But ideally, number two, it'd be great if, and I've been hearing this, I told Marla when she came, I went to a advanced IBD course when I was a fellow. So 2005. And even then she said, it's not really Crohn's and colitis. It's IBD1, IBD2, IBD3, IBD4. Like every patient has their own presentation, their own phenotype, their own serologies, and now you could say their own genetics, and now you could say their own microbiome. I mean, there's so many different configurations, and if we can identify patterns or characteristics where, this gene with this microbiome and this serology will not respond to Entyvio, great. We won't use it. So we want to personalize our therapies because we want to find out, instead of wasting time using ones that don't work with potential side effects, jumping right to the one that we have data on that will work. So that's ultimately where I hope the field will go.
Yeah, I agree. I think that certainly is what the patients are looking for too, is the ability to say, this is exactly what you will respond to, based on all of the factors that we understand. So I agree with you. Hopefully we'll get there sooner rather than later.
Amazing. Yeah.
So here's your first off the wall question. Again, I was doing a little bit of digging on you, and I suddenly found that you are involved in a clinic in Agua Prieta, Mexico.
Wow. I didn't even know that was out there.
I can find you.
But yes, that's been really, really cool. So I'll try to make the story short. But one of my nurses that I work with, we were at a Christmas party, I think it was like a year ago, our holiday party, and was talking to her and her husband. And it turned out her husband was part of the same fraternity that I went to Binghamton University, upstate New York. I was in SAE in Binghamton. He was in SAE down in ASU, but he's the head of the alumni of all of Arizona. And for me, it was just an outlet. It was not by any means going to be the focus of my future, and I've not been involved, but he said, why don't you just come? And actually he told me I was going to get some award for what I've done in the medical field, and they give out an award every year, and they're having their award ceremony for that year, and I was invited. So I went, and I met this amazing man named Gil Gillenwater, who was part of the fraternity and was very successful in the real estate industry, and he was traveling. We're very close to Mexico here, and he was traveling to Mexico and took a wrong turn and ended up in this very impoverished community, but found the people to be so endearing and welcoming and amazing that he just started helping out there, and he created a charity to just give back to that community. And he's been doing it since 1985. So it's been around forever. And what's great is he's just gotten so many amazing people on his board, and he gives this great story, and it's just so riveting. And I was just drawn into his passion, and he's all about feeding your soul and how that's the real gift, and all this monetary stuff is nothing. And once you do philanthropy, you really get to feel what it's like to be rich. And it was just a very moving talk. And he sat next to me at the dinner. And afterwards I went to him, I said, so you donate food, you donate clothes. They actually built a dormitory for volunteers because he said he wants people who have the means to come down there and volunteer and feel comfortable and feel like they're getting taken care of just as much as they're taking care of the community. So he built this like incredible dormitory. It's literally, when I got there, it's like a 5-star hotel, and they provide food, and they had a mariachi band. He wants it to be a cultural experience. And so I started talking to him, and he's telling me they help the orphanage out, they help the migrant center for all the deportees, and they fund that. They also do dog adoptions, and I mean, they really do a ton of work. And I said, what about medicine? And no, they don't have any medical program. So I said, well, seems like that's needed. It seems like we should create that. So literally within about 6 months, I had gone down there. I met the pediatricians in the community. We had a meeting with them, and then some of the government officials, the consulate, all these people, and just started bouncing ideas off each other, and ultimately have the workings of our clinic. And it's going to start, our first inaugural clinic is going to be in May, and it's going to be a 1-day clinic. We're going to have 200 and we're doing only pediatrics. We're focusing on that. I managed to find a bunch of amazing partners. Lara Yablonsky, who's the head of our global health program at PCH, 2 residents with her, and Michael Blasik, who's on the board there, used to be on administration, I think CFO or someone high up at Dignity Health. And so we've all been working together, and yeah, I mean, we're in the phase of recruiting volunteers. We've got the clinic planned out. And what's amazing is we've got this WhatsApp list and it's just a combination of the Mexican pediatricians and us. And it's just crosstalk and communication over, hey, what meds do you have? What meds do you need? What equipment should we bring? And working together. And it's been, every time I go there, it's incredible. And the first time I went, I couldn't stop talking about it. And it was literally one weekend, but I felt like I was there forever. You just make so many close connections. And I told my wife about it, and she came down another time, and she was like, I get it. Like, this is amazing. And so.
That's really amazing. I'm really excited to hear how it goes after you do your first clinic. And it's so encouraging to see this many people pitching in and opening up their, do they Rolodex anymore? I mean, this is such an old, that's such an old lady thing to say, but
their
opening up
contact list.
Hitting up their WhatsApp. Yeah. Anyway, I'll stop trying on that one, but that really is awesome. I'm going to be really interested to hear how that goes. You'll have to give us an update. Okay. Second random question for you. By any chance, are you related to Boris Pasternak, the author of Dr. Zhivago?
Dr. Zhivago. I get asked that. Well, I used to get asked that all the time in college and high school. And the answer is probably, I haven't found the connection, and I've done Ancestry and 23andMe, and he hasn't shown up. But when I was in college and in my literature classes, then I was always related.
Okay. Of course. Absolutely.
Oh,
Absolutely.
Yeah. We go way back.
Okay. That one was a real wild one for you.
Mm-hmm.
All right. Well, Brad, it has been such a pleasure talking to you, but I know we are out of time with you. So last question for you is, if you had one piece of advice for the IBD community, what would it be? And in your case, for our professionals, we do say if you have one for professionals, great. One for patients, great.
So yeah, for patients, I think my advice would be to not let the disease control you. And I'm not saying be like me. I mean, I don't want to sound arrogant or toot my horn, but don't let the disease define you, but let it drive you. And, realize that there's so many therapies on the horizon, and life does not have to be as altered as maybe people think. There are newer drugs coming out. There's a lot more out there now than there used to be, and to keep their heads up and maintain hope. And then for physicians, I just say, find your passion. For me, I wake up and I don't growl about having to go to work. I enjoy it, and it's a passion for me. And so it's not work. And the other thing is connect with your patients. That's my biggest pet peeve with, trainees, where they go in and they list off the differential and what we're going to do. And it's like, so what's her hobby? What sport does she play? And they're like, oh, I don't know. They're not textbooks. And I have become so close with so many of my patients to the point where I feel like some of them are family. I mean, I've gotten to that point, and that's what makes it rewarding, where they totally appreciate it. And if you know them on a personal level, it's a very different interaction than looking at them as just a patient MR number that walks in your door. So that's the other piece of advice for practitioners.
I love that. Having that personal relationship with your physician helps build trust too.
Mm-hmm. And if you're doing IBD and you're a physician, go to the camp.
Agreed.
It will change you because you get to see these kids in their environment, and you get to interact with them on a different level. And I think it's just important, and an important part of training and understanding the disease.
I love that plug. They can always use doctors at the camp. That's true.
Yeah, absolutely.
Yes. Yeah, it's a very, very powerful. And it's one of the only places where the kids can just go and just be themselves and be around people that understand that, like, hey, I'm going to be longer in the bathroom, or I might need to lay down because I'm fatigued, and just nobody questions, and you can't stop making poop and fart jokes. So
yeah,
it's how we get through life. Thank you so much for joining us, Dr. Pasternak, and sharing so openly. It was fascinating, some of the things you were talking about. And also, I'm sorry that you had to give mice enemas on a daily basis, but we appreciate you.
I picture just like tiny little enema bottles. I'm like,
me too.
They're very tiny.
Okay, we're going to start talking about something else again. So I'm going to say thank you so much for joining us, and thank you to everyone for listening, and cheers.
Cheers.
Hi, this is Dr. Pasternak, and if you enjoyed this episode, please rate, review, subscribe, and share with a friend.